Bismillahirrahmanirrahim. Let's start the session 2 of the reproductive unit. So here we are going to talk about the organs with a special embryologic origin. The pituitary gland. Anterior pituitary comes from the adenohypophysis from the rachis pouch of the ectoderm, that is surface ectoderm, and outpouching of the outer of the upper mouth. So basically there is an outpouching of the upper mouth. Uh, I can't draw a very good diagram of that, but suppose that this is the face of a person and it is the outpouching of the for the oral mucosa or the oral ectoderm, suppose, and here is the rachis pouch that is representing like that, and over here there's the brain of the person with the pons middle and all that. So that's a very bad diagram, sorry. So suppose this is the brain like that, and here's the brain stem, something on those lines, and here we have the posterior pituitary or the neurohypophysis. So during the embryologic development, this adenohypophysis breaks down from here, and both of these structures come together to form the pituitary gland. The pituitary gland which we have in the adult human being. So that basically the adenohypophysis is originating from the rachis pouch, that is surface ectoderm of the oral surface ectoderm, the outpouching of the upper mouth. Posterior pituitary, the neurohypophysis comes from the neural tube or the neuroectoderm, and these two lobes fuse together, and among both of them, the adenohypophysis is the gland, like it is producing its own hormones, while the posterior hypophysis or the neurohypophysis is mere extension of the hypothalamic. It is just a center where the hypothalamic hormones will get lodged into the circulation. So it is nothing, it is not producing any of its own hormones like oxytocin and the other one, the ADH. They are not the hormones of the posterior pituitary, they are just the hormones of the hypothalamus which get secreted from this area, like the neurohypophysis. Then adrenal gland, the cortex is coming from the mesoderm, while the medulla is coming from the neurocrest cells. Moving forward, we have type of error in the morphogenesis. Errors can be intrinsic, then intrinsic include all of these following, then other are extrinsic pathways and so let's talk about the intrinsic factors. So failure of embryo to develop, abnormal genes or internal processes, for example agenesis, aplasia, hypoplasia, or malformation. These are the examples of intrinsic errors of morphogenesis. So morphogenesis means the development of organs of the fetus. So that development of the organs is not happening. Basically organ development is organogenesis, but for the morphogenesis you can say the form or the adult form of the human being is not being formed. So that morphogenesis error, if it is, we are talking about the intrinsic errors, so they include the agenesis, aplasia, hypoplasia, and malformations. So firstly we'll talk about agenesis. Absent organ due to the absent primordial tissues. Examples include renal agenesis. Suppose renal agenesis means that a kidney or both of kidneys are not being formed at all. So that is agenesis, absent organ due to the absence of the primordial tissue. Then in the case of aplasia, absent organ despite of the presence of primordial tissue. For example, in the case of thymic aplasia, the primordia are present, but the structure has not been formed. That is called as aplasia. Agenesis means the structure has not been formed in first place. The aplasia means that the structure's primordial tissue was there, but that primordial tissue did not differentiate into formation of the complete structure. For example, the thymic aplasia. Then hypoplasia means incomplete organ development. Primordial tissue is present. For example, microcephaly. The primordial tissue is there, but the organ has not been developed completely. Then malformation, that is abnormal development of the structure. For example, primary defect in the cells or tissue that form an organ, that is intrinsic disruption, can be there, occurs during the embryonic period from 3rd to 8th week. Examples include neural tube defect, holoprosencephaly, which occurs early in the 5th week of fetal life, congenital heart diseases, polydactyly and syndactyly, and cleft palate or cleft lip. So these are all examples of malformations. So there are problems with the formations. They can either be agenesis, either they can be agenesis, which means there is no structure at all, neither primordia nor the organ. In the case of aplasia, the primordium is present but the organ has not developed. In the case of hypoplasia, the organ has not developed completely, for example the microcephaly. And in the case of malformation, the organ is not formed in the right way, like there is an abnormal development of that particular structure. Moving forward, we have extrinsic defects. So external forces impact the normal development. The pressure applied by the uterus is one of the most common external forces. Examples include disruption and deformation. So now the problem is not with the fetus or inside the fetus, the problem is outside the fetus. And what is outside the fetus? First thing is uterus, and the second thing, first thing is amniotic sac, and second thing is uterus. So talking about disruption, the normal tissue growth arrested due to external forces, secondary breakdown of the previously normal tissue or structure. So disruption means that normal tissue growth is arrested due to external forces and secondary breakdown of the previously normal tissue or structure. Classic example is amniotic band syndrome. Fetal structure entrapped by the fibrous bands in utero often involves the limbs or digits. So you can see here that this is a particular finding that we see in the case of amniotic bands, and here is another picture of amniotic band formation. So this means that due to some reason the amniotic cavity has turned into bands, and those bands are surrounding the limbs, mostly the limbs, but other structures can also be surrounded. So whatever structure is surrounded, that will be disrupted, the growth will be disrupted, and that will be broken down, and this particular thing is called as disruption. Then we have deformation. External force leads to the abnormal growth, not arrest. So there will be abnormal growth, not arrest, occurs after the embryonic period. Example is the Porter sequence. Uterine constraints on the fetus in the breech position can cause congenital dislocation of hip or the club feet. So what happens in the Porter sequence, if there is renal aplasia, or maybe there is some persistence of the Wolffian duct which is causing the formation of the posterior urethral valves, or some other cause of the oligohydramnios is there, like the amniotic fluid is decreased in quantity. So what happens that there will be oligohydramnios, and the pressure will be applied on the fetus because the fetus will be completely wrapped in the amniotic fluid. Resultantly, there will be a Porter syndrome in which there will be flat faces, and the fetus will be having clubbed feet, and the lung hypoplasia will be there. So that is called as Porter syndrome because of the external force that is being applied on the fetus by the amniotic sac. Uterine constraint on the fetus is the breech position. The fetus is in the breech position. Congenital dislocation of hip can be seen, or clubbed feet due to some external pressure can also be, for example, the Porter sequence, but that is an example of the deformation. Then what is the sequence? Abnormalities result from a single primary embryologic event. For example, the oligohydramnios lead to the Porter sequence. That is a sequence. So all of the syndromes, like the findings, suppose we have a syndromic baby. If all of the findings of the syndromic baby can be characterized to a single cause, that is called as a sequence. For example, in the case of a Porter sequence, the oligohydramnios is the sole cause of all the constellation of symptoms we find in the patient. Now we will talk about teratogens. Okay. Actually, let me see. Okay, now we are talking about teratogens. So let us go to the teratogens. Okay, teratogens. Teratogen timing: first 2 weeks, all or none period, spontaneous abortion or no effect at all. So that is all or none period, which means that in the first 2 weeks, when there is epiblast and hypoblast formation, either all of the cells will be involved or mutated, or none of the cells is involved. So if all of them are involved, so the fetus will be aborted, or there will be no effect on the fetus. From week 2 to 8, that is a very critical period because that is a period of organogenesis, and there will be structural defect if the teratogens affect the fetus in that particular time. Week 8 afterward, there will be decreased growth, central nervous system dysfunction, or usually no birth defects. So the birth defects are characteristic for this period, like from week 2 to week 8. Drug categories. So there are different categories. These are the drugs which are normally taken, like the normally taken drugs for different conditions have been classified into A, B, C, D and X categories depending upon the teratogenic potential. So the drug A, it has no risk for the fetus in human studies, so we did human studies and there was no risk found. Then for the drug B, no risk for the fetus in other studies, we did not do the human studies, but we did the animal studies and there was no risk to the fetus in animal studies. Choice drug category C, risk cannot be ruled out. Okay, we can't rule out the risk. The risk was not very evident, but it can not be ruled out either. Choice D, there is positive evidence of the risk. And category X, I'm sorry, it's not choices, it is categories. And then we have category X, that is contraindicated in pregnancy in all situations. Like let's talk about the retinoic acid, or maybe we are talking about the the tetracyclines or the stuff like that, aminoglycosides. So these are teratogenic. Drugs known to be teratogenic in animals and humans, risk clearly outweighs the benefits. Then we have teratogenic medications. Okay, just yep. So teratogenic medications, ACE inhibitors, they can cause renal damage. Okay, we suspect renal damage with the ACE inhibitors. Alkylating agents, uh, alkylating agents. I guess the alkylating agents are the one which we use in the chemotherapy, like the ones alkylating agents include the cisplatin. Yes, but those are platinum analogs, alkylating agents. I guess alkylating agents include uh, cyclophosphamide. Maybe I'm not sure. Okay, so alkylating agents, they will be absent of digits and multiple anomalies will be there. Then aminoglycosides can cause ototoxicity. Amine guy hit the baby in the ear. Then anti-epileptic drugs, neural tube defects, cardiac defects, cleft palate, skeletal abnormalities, for example, failings to nail hypoplasia and facial dysmorphism. High dose folate supplementation recommended. Most commonly valproate. Valproate is very notorious for this one. Valproate, carbamazepine, phenytoin, and phenobarbital, they can cause these effects. Then diethylstilbestrol, this is no more used, but it was used previously. So vaginal clear cell adenocarcinoma and congenital Mullerian anomalies can be seen. Then we have fetal antagonists. Folate antagonists. They can cause neural tube defects, include the trimethoprim, methotrexate, and anti-epileptic drugs. Then we have isotretinoin, multiple severe birth defects. Contraception is mandatory. Isotretinoin. Then lithium, it can cause Epstein anomaly, apical displacement of the tricuspid valve. So what happens in the, it is apical displacement of the tricuspid valve, right? So what happens is, let's suppose this is the heart, and this is the right side. So normal position of the tricuspid valve was supposed to be like somewhere here, but the tricuspid valve shifts downwards all the way. It shifts downward all the way till like here. So there will be like very big atrium. So this concept is called as the atrialization of the ventricle. So let's move on. Methimazole, it will cause aplasia cutis congenita. Okay, then we have tetracyclines, they can cause discolored teeth, inhibited bone growth, you can pronounce them tetracyclines. Then thalidomide, limb defects, phocomelia, micromelia, or flipper limbs. Okay, limb defect with a thalidomide. Okay, so that is thalidomide or can cause limb defects, phocomelia, micromelia, and flipper limbs. Okay, so search them in the Google. Then we have warfarin, bone deformities, fetal hemorrhage, abortion, ophthalmologic abnormalities. Do not wage warfare on the baby. Keep it happy. With heparin, does not cause a placenta. So heparin. Okay, let me remove that. So we can give heparin to the mother who are having some coagulopathies. So we can give them heparin instead of warfarin. Because heparin is safe in the pregnancy. So keep it happy with heparin, does not cause the placenta. Then ACE inhibitors can cause oligohydramnios, and that oligohydramnios will lead to the Porter sequence. Then we have skin defects of oral isotretinoin therapy. Side effects of oral isotretinoin therapy, they are teratogenic, for example spontaneous abortion, fetal malformations, hyperlipidemia, cheilitis and dry skin, myalgias, and pseudo tumor cerebri will be seen. Then we have complications in the diethylstilbestrol daughters, clear cell adenocarcinoma, because vagina and cervix are present in the females mostly. So diethylstilbestrol daughters will have clear cell adenocarcinoma of the vagina and cervix, structural anomalies of the reproductive tract, hooded cervix, that's an important finding, hooded cervix and T-shaped uterus, small uterine cavity, vaginal septum, and the vaginal adenosis. Then we have pregnancy problems, for example ectopic pregnancy and preterm delivery and infertility. After that we have antibiotics contraindicated during pregnancy, tetracyclines because they can cause teeth staining, chlorphenicol because that can cause gray baby syndrome, trimethoprim sulfamethoxazole because they can lead to the neural tube defects, and aminoglycoside because they can cause ototoxicity and vestibulotoxicity. Fetal Hydantoin syndrome. Fetal hydantoin, like it rhymes with a phenytoin, so it is caused by phenytoin, associated with the phenytoin used in the pregnancy. Okay. Growth deficiency plus abnormal faces, uh, broad nose, broad short nose, wide spaced eyes, malformed ears, microcephaly, classically cleft lip and cleft palate, that is called as the fetal hydantoin syndrome, caused by the phenytoin. There will be growth deficiency with abnormal facial features, broad based nose, wide spaced eyes, malformed ears, microcephaly, classically cleft lip and cleft palate. Then we have warfarin, embryopathy, fetal hemorrhage and spontaneous abortion, optic atrophy that leads to vision loss, bone and cartilage abnormalities, stippled epiphysis, small and round densities on the X-ray, and nasal and limb hypoplasia will also be seen. Then substance abuse in pregnancy. So substance abuse, if it includes alcohol, common cause of birth defects and intellectual disability, and fetal alcohol syndrome can be seen. Cocaine, low birth weight, preterm birth, intrauterine growth restriction, that is IUGR, and placental abruption. Cocaine causes vasoconstriction. So whenever there is vasoconstriction, that vasoconstriction lead to the low birth weight or the preterm birth and intrauterine growth restriction, placental abruption. Okay, smoking, nicotine, low birth weight. Okay, leading cause in the developed countries. So leading cause of the low birth weight in the developed countries is the smoking. Then we have preterm labor, placental problems, intrauterine growth restriction, SIDS is sudden infantile death syndrome, and ADHD is attention deficit hyperactivity disorder. What is ADHD? I guess ADHD is that. Okay. Nicotine causes vasoconstriction, and carbon monoxide, which can be coming from the smoke, it can cause impaired oxygen delivery because it will bind to the hemoglobin very strongly and it will not allow the already bound oxygen to be released into the peripheral tissues, so it can impair the oxygen delivery. What is fetal alcohol syndrome? So it is the leading cause of intellectual disability in the United States. Alcohol is neurotoxic by many mechanisms, mostly failure of cell migration. First trimester, there will be facial abnormalities. You can find smooth philtrum, groove from the base to nose, groove from, so smooth philtrum is basically the normal groove from the base of nose to the upper lip, and that is smooth in these cases. As you can see over here, there is a smooth philtrum. Then we have like a smooth philtrum, and then short palpebral fissures. So the palpebral fissures are small. Palpebral fissure is basically the opening, the visible part of the eye. Like palpebra is the eyelid, so the distance, the eye which is visible between the upper and lower eyelid is present in the palpebral fissure. So that is called as a palpebral fissure. Small opening of the eyes and thin vermilion border on the upper lip. The upper lip will be very thin. As you can see, it is a characteristic picture of a child in which there is a very smooth philtrum and there is a very thin vermilion border. On top of that, there is a very small palpebral fissure as well. Okay. Then brain abnormalities, microcephaly will be there. On top of that, small corpus callosum, cerebellum and basal ganglia will be there. Hypotonia and holoprosencephaly. Holoprosencephalon, maybe there is a picture of that later on. Okay, there is no picture of that. So in the holoprosencephalon, we find that normal brain looks something like this. Like these are hemispheres, so they look something like this. And the ventricles, they like, if this is a one ventricle, so it is connected. No, it goes like this. Like suppose I'm drawing the lateral ventricles. So the lateral ventricles, they connect on each side to the fourth ventricle. Suppose this is one ventricle over here, and here we have another ventricle. So both of them, they collectively are connected to the third ventricle, and the third ventricle will then go to the fourth ventricle and all that. So I'm sorry for the bad diagram. So both of them, they are connected to the third ventricle like that. But in the case of holoprosencephaly, firstly there is only one brain. There is no midline feature. On top of that, the ventricles are also fused together. So third ventricles are like together. So this is a characteristic picture of the holoprosencephaly that is seen in the patients or in the children who have been influenced by the acid intake in the mother. So congenital heart diseases include ASD, VSD, and tetralogy of Fallot, heart and lung fistulas. Third trimester mostly affect the size of the baby, okay, brain and growth. So this was in the first trimester. If alcohol exposure happens in the first trimester, that can present with the facial abnormalities, brain abnormalities, and congenital heart diseases. Because first trimester is the early in the first trimester there is organogenesis, but late in the first trimester the following changes can be seen. In the third trimester, mostly the size of the baby is affected and brain growth, below average height and weight. Limb defects include finger contractions, congenital hip dislocations. Intellectual impairment may occur without facial or brain anomalies. Heart lung fistulas and hollow prosencephaly is the most severe form. So heart lung fistulas and the hollow prosencephaly is the most severe form of the intellectual impairment that can be seen with these patients. So microcephaly is there, and then we have the fetal alcohol syndrome and thin Vermeer bottle. So we have seen these characteristics, and this happens if the alcohol exposure was in the first trimester. Then we have other teratogenic agents. Iodine, either lack or excess, can cause congenital goiter or hypothyroidism, that is called as seretinism. Maternal diabetes, caudal regression syndrome, anal atresia to the to cyranomelia. Let me see that. Cyranomelia. So this is cyranomelia. It is a rare congenital abnormality with a characteristic feature of the complete or partial fusion of the lower limbs. Although this syndrome is incompatible with life due to the association with several congenital visual anomalies, however, there are few reports of surviving infants. Okay. So this is the picture of cyranomelia. It is like, give me a second. So it is over here. So the children look like mermaids or something. So this is cyranomelia, and like, you know, a mermaid or something. So this is not compatible with life, by the way. And yep. So let's come back. So here you can see maternal diabetes, caudal regression syndrome, that is anal atresia to the cyranomelia. Congenital heart defects, for example, VSD, transposition of great vessels. Neural tube defects, macrosmia, neonatal hypoglycemia, and polycythemia. Methyl mercury is causing the neurotoxicity. Okay, it will cause neurotoxicity. Highest in the swordfish, shark, tealfish, king merkel. So methyl mercury is present in high concentration in these fishes. So if the mother has been consuming these fish in high quantity, so that can cause neurotoxicity. Vitamin A excess, extremely high risk of spontaneous abortion and birth defects, for example cleft palate and cardiac anomalies. X-rays can cause microcephaly and intellectual disability, minimized by the lead shielding. Okay, then what is caudal regression syndrome? Okay, caudal regression syndrome, cyranomelia, right? So classically associated with the maternal diabetes, may include anal atresia, sacral agenesis, or incomplete development of sacrum. May include cyranomelia, that is mermaid syndrome. Fusion of the legs will be seen, like something like that. Often includes a neural tube defect. Then maternal phenylketonuria. It occurs in the women with a phenylketonuria who consume phenylalanine. High level of phenylalanine acts as a teratogen. So occurs in the women with a phenylketonuria who consumes phenylalanine. High levels of phenylalanine acts as a teratogen. Serum phenylalanine should be monitored in the pregnancy. Dietary restriction of the phenylalanine is essential. Phenylalanine is a teratogen, causes similar effects as alcohol in intrauterine growth restriction and microcephaly, intellectual disability, for example mental retardation, congenital heart defects, coarctation of aorta, hypoplastic left heart syndrome. So these are the findings which we find in the case of maternal phenylketonuria. Then neonatal abstinence syndrome. Okay, so complex disorder involving the CNS, ANS, and GI systems. Secondary to the maternal opiate use and abuse. Risk factors for the maternal substance abuse during the pregnancy include poor mental health, poor prenatal care, low SES, what is that? Lack of family support and HCV, low socioeconomic status, lack of family support, and hepatitis C virus. So these are the risk factors. Universal screening substance abuse is recommended in all the pregnant patients. Newborn may present with uncoordinated sucking reflexes, irritability, high-pitched crying, tremors, tachypnea, sneezing, diarrhea, and possibly seizures. So these are the findings of the neonatal abstinence syndrome. There will be high-pitched crying, seizures, temperature instability, tremors, sleep problems, sneezing, and feeding difficulties. So decidua capsularis, and why is it drawn over there? Uterine cavity is that, and we have the residua basalis, with which the implantation, where the implantation of placenta is happening. Then we have decidua capsularis, that is encapsulating the fetus. Then decidua parietalis, the parietal decidua, and then uterine cavity is present between them. So these are three types of decidua. Then let's talk about placenta. Primary site of the nutrient and gas exchange between mother and fetus. So placenta is the primary site for the nutrient and gas exchange between the mother and fetus. Decidual reaction, endometrium reaction at implantation. Decidua altered uterine lining during the pregnancy. What is decidua basalis? Uterus at the site of implantation, it interacts with the trophoblast. So suppose that there is a placenta, and with a cord, like here the fetus, like over here, something like this. So this particular area, let me draw that with suppose this color. So the area with which the placenta is adherent, that area is called as decidua basalis. Decidua, it interacts with the trophoblast. Decidua capsularis, it surrounds the fetus. So the part of the decidua that is surrounding the fetus is called as the decidua parietalis. And what is that is called decidua capsularis, it surrounds the fetus. And decidua parietalis is opposite wall of the uterus. So suppose that this is the uterus as a whole, like this, and decidua basalis was like here, and then we had the decidua capsularis, and this particular decidua, the wall of the wall of the uterus, that is facing opposite to the site of implantation of the uterus, is called as the decidua parietalis. Then we have it. Give me a second. Then the membranes include amnion, chorion, and these are two membranes. So amnion is the inner membrane that covers the fetus, holds the amniotic fluid, and protects the embryo. So what is amnion? Amnion is the inner membrane that covers the fetus. It holds the amniotic fluid and protects the embryo. What is chorion? So where is amnion? Amnion is like amniotic cavities over here. So where is amnion? This is amniotic cavity. So it holds the fetus like this. This would be amnion. What is chorion? Membrane that surrounds the amnion or embryo. It is derived from the trophoblast and supports the fetus and amnion. The amnion will protect the embryo, and the layer that supports the fetus and amnion, that is called as chorion, so that is present outside there. So this is chorion frondosum. Chorionic cavity is like outside the amnion. So if I could zoom it in over here, like if you can see this. So this particular layer is called amnion, like this one, and the surrounding so this one is amnion, like the inner one, and surrounding that, this particular one is the chorion. So these are the two layers. Okay. So amniotic cavity is inside, and then decidua basalis and decidua parietalis, capsularis, chorionic cavity, blah blah blah. And here we have the fused decidua parietalis and capsularis, decidua basalis, chorion frondosum, and amniotic cavity. Then we have components of the placenta. There are two components: fetal component or maternal component. The fetal component include the chorionic plate, that is chorionic villi. So the fetal component include these two things, either cytotrophoblast or the syncytial trophoblast. So chorionic plate is equal to chorionic villi. The cytotrophoblast, the inner layer of the chorionic villi, they proliferate, cell migrate into the syncytial trophoblast, and cytotrophoblast makes cells. Okay, so the cytotrophoblast, the inner layer of the chorionic villi, proliferate, cell migrate into the syncytial trophoblast. So suppose that this is a particular layer. I'm not drawing all of them, but suppose this is a layer with a cell, like these are the cells. So this is cytotrophoblast, and outside this we have the syncytium of the cells, like this particular thing is the syncytial trophoblast. Outside that, they are just nuclei, like isolated nuclei over there, and there is nothing, you cannot find a cell over there. So the cytotrophoblast, they are responsible for the formation of villi. Firstly, the villus structures are formed by the cytotrophoblast, the cellular villi, and secondly, there will be cells which will be sloughed off to form the syncytial trophoblast. So cytotrophoblast makes the cells, and those cells will migrate into the syncytial trophoblast. Then syncytial trophoblast is the outer layer the chorionic will lie. Synthesizes and secretes the hormone. For example, the beta HCG is secreted by the syncytial trophoblast, structurally similar to luteinizing hormone. So the beta HCG that is produced, but basically it is beta HCG. Beta HCG that is produced by the syncytial trophoblast is structurally similar to luteinizing hormone. It stimulates the corpus luteum to secrete the progesterone during the first trimester. Syncytial trophoblast synthesizes the hormones, and cytotrophoblast makes the cell. Cytotrophoblast is the inner one, while the syncytial trophoblast is the outer one. Remember this. Then maternal component, it is the basal plate, decidua basalis, derived from the endometrium. Maternal blood in the lacunae will be seen. So over here we have the endometrial vein, endometrial artery. So now this is the mature version. There is no syncytial trophoblast or cytotrophoblast form like structure like that. It is a mature version of the placenta. So in the case of the maternal component, that is basically the the decidua basalis is the basal plate that is given by the mother as a part of the placenta. Now here we have the placental barrier. So this is branch will lie over here, like, okay. Then we have umbilical vein. One umbilical vein is there and two umbilical arteries are seen. Then it is the amnion, and amnion will be surrounding by another layer that will be chorion. Okay. Then we have the chorionic plate, and the maternal blood is over here, like where maternal blood is basically present in the the lacunae. So decidua basalis is this, and then we have the endometrial vein and endometrial artery, and this is the maternal circulation. Then this is fetal circulation. Fetal circulation passes carbon dioxide, water, urea, waste products, and hormones to the maternal circulation via placenta. From the maternal circulation, oxygen, water, electrolytes, nutrients, hormones, IgG antibodies. So Dr. Nandan Joshi gave a mnemonic like IgG greets the fetus. So then we have drugs and viruses. So all of these things are moving from the maternal circulation to the fetal circulation. Here we have syncytial trophoblast, and then it is cytotrophoblast. So the inner one that is facing towards the fetus is the cytotrophoblast, and the one facing towards the mother is the syncytial trophoblast. So remember it like that. Immunology of the pregnancy. The fetus has foreign antigens. Half of the genes from father, which are HLA protein, different from that of the mother, protected from the maternal immunity by placenta. So placenta is giving like it is protecting the fetus from the immune responses as well. There are several mechanisms to that. So trophoblastic cells do not express the MSC class 1 antigen. That is very important one. That the trophoblastic cells, like the syncytial trophoblast, which is facing the mother, or even the cytotrophoblast, they don't have the MSC class 1. Now MSC class 1 is a it is a surface protein presenter which presents the intrinsic proteins on the surface of the cell, while the MSC class 2 we know that about MSC class 2 that MSC class 2 presents the external proteins, like the breakdown products of the bacteria and stuff like that. So those external proteins are expressed by the MSC class 2. In contrast to that, the MSC class 1 will be presenting the intrinsic or the the intrinsic proteins of the body. Then placenta secretions block the immune responses. So these are two mechanisms. The trophoblastic cells, they don't have MSC class 1. So if there is nothing on the MSC class 1, or if there are no MSC class 1 at all, so immune surveillance mechanisms won't be able to recognize them. Secondly, the placenta secretion block the immune response. Okay, here you can see this is the, what is it? It is pharyngeal pouches, and okay, so these are pharyngeal pouches, and we're not concerned about that right now. Yolk sac will lead to the formation of Whitline duct. Allantois will lead to the formation of uric acid. So these two derivatives are very important. That the yolk sac gives rise to the Whitline duct, while the allantois gives rise to the uric acid, and yolk sac and the allantois together will give rise to the umbilical cord. Okay, so these things are called the pharyngeal pouches. Here we have the esophagus, the celiac trunk, and this form the foregut. Then we have the midgut with the superior mesenteric artery, and the hindgut with the inferior mesenteric artery. So umbilical cord, two umbilical arteries, they are responsible for returning the deoxygenated blood from the fetal internal iliac arteries to the placenta. From where? The fetal internal iliac arteries to the placenta. So the two umbilical veins are returning the blood from the fetal internal iliac arteries to the placenta, and that blood is deoxygenated. So here you can see the blue ones are the two umbilical arteries. Then one umbilical vein supplies the oxygenated blood from the placenta to the fetus. drains to the inferior vena cava via liver or via ductus deferens. So it drains into the inferior vena cava via liver or via ductus venosus. Okay, got it. So the one umbilical vein will drain into the the inferior vena cava either via liver or via ductus venosus. Then what is Wharton jelly? So the Wharton jelly is a stabilizing material. So here you can see this is Wharton jelly. It contains the mucopolysaccharides similar to the vitreous humor. Allantoic duct. What is that? It connects the fetal bladder to the umbilical cord. So allantoic duct connects the fetal bladder to the umbilical cord, obliterates in development, becomes urachus. NBME point is umbilical arteries and veins are derivative of the allantois. Okay, umbilical arteries and veins, they are the derivatives of allantois. Okay, then we have single umbilical artery, two vessel cord. So abnormal variant often identified on the prenatal ultrasound associated with the fetal abnormalities like aneuploidy or congenital malformations. So the children who have aneuploidy or congenital malformations may also have a single umbilical artery or two vessel cord. Normally it is a three vessel cord. What is allantois? It is outpouching of the gut wall, extends into the urogenital sinus, walls form the umbilical blood vessels, and the lumen becomes urachus, a duct between the fetal bladder and umbilicus. Obliterated urachus is represented by the median umbilical ligament. This is very important. So any remnant of the embryologic structure is very important because they ask you about that in the step exam. So the obliterated urachus is the median umbilical ligament after birth, which is covered by the median umbilical fold on the peritoneum. And the second thing is that the walls of the this is something that is coming from the lumen of the allantois. The wall of allantois is going to form the the umbilical blood vessels. Then what is urachus? Failure of urachus to involute can lead to the anomalies that may increase risk of infection or malignancy, for example adenocarcinoma if it is not treated. So failure of the urachus to involute can lead to the anomalies that may increase the risk of infection or malignancy, for example adenocarcinoma if it is not treated. So here are some pictures, like it is umbilicus and normally there is just a fibrosed connection between the bladder and the umbilicus. If it is not closed, that is called as patent urachus. Okay, so total failure of the urachus to obliterate urine discharge from the umbilicus can be seen. This one. Then we have urachal cysts. Partial failure of the urachus to obliterate fluid filled cavity lined with a uroepithelium between the umbilicus and bladder. So it is a fluid filled cavity lined with urothelium between the umbilicus and bladder. So here you can see it is a urachal cyst. Cyst can become infected and present as a painful mass below the umbilicus. And what is vesico-urachal diverticulum? So this is vesico-urachal diverticulum. Slight failure of the urachus to obliterate, outpouching of the bladder. So it was supposed to be like fibrosed till here, and if it is not fibrosed, so there will be an outpouching of the bladder, something like this. So this is the outpouching of the bladder, and that outpouching of the bladder is forming the vesico-urachal diverticulum. Then we have Wittline duct. 7th week, obliteration of the Wittline duct form the omphallomesenteric duct which connects the yolk sac to the midgut lumen. So on the 7th week, obliteration of the Wittline duct or omphallomesenteric duct which connects the yolk sac to the midgut lumen. Wittline fistula. What is Wittline fistula? So the one which we previously have studied, that was urachus, right? So urachus was coming from the allantois, and now we are talking about Wittline duct. Wittline duct is 7th week, obliteration of the Wittline duct or omphallomesenteric duct which connects the yolk sac to the midgut. Now the Wittline fistula, normally it is not connected to anything, but if there is Wittline fistula, so Wittline duct fails to close, meconium drainage from the umbilicus can be seen. Okay, if there is Wittline fistula, so there will be meconium drainage from the umbilicus. And what is Meckel's diverticulum? The partial closure of the Wittline duct with a patent portion attached to the lumen, that is called as true diverticulum. Why is it called true diverticulum? Because all the three layers of the the intestines will be outpouching, including the mucosa and submucosa and the serosa. All of them will be outpouching, will be forming the diverticulum. So that is called as Meckel's diverticulum. So partial closure of the Wittline duct with the patent portion attached to the lumen, that is true diverticulum. May have heterotopic gastric or pancreatic tissue. So that is a choristoma. That is an example of choristoma in which the Meckel's diverticulum contains cells from some other organ, like from the GIT or from some pancreatic tissue, that leads to melena, hematochezia and abdominal pain. So it is umbilicus and Meckel's diverticulum is something like this one. So Wittline fistula is a condition in which there is a patent connection between the urachus, urachus nahi, patent connection between the umbilicus and the intestine of the Meckel's diverticulum. It's not a Meckel's diverticulum. It is basically Wittline duct fails to close, so meconium discharge from the umbilicus can be seen. Okay, and in the case of Meckel's diverticulum, the partial closure of the Wittline duct with a patent portion attached to the ileum, that is the true diverticulum. So remember these things. Then we have the concept of dizygotic twins and a very gruesome detail of that. Okay, and then we have the arch derivatives. So we will keep this session till here, and we will continue with the next session after the break. So until then, fi amanillah.